time for our session. Okay, Lydia's here. Okay, and then Joe. Okay, so very welcome. Everybody comes to our session today. This session is on impact. I will briefly summarize our session and the background of the topics and some of the objectives we want to reach at the end of the session. First of all, indoor air quality has become a global concern affecting billions of people. This session, we want to examine the air pollution indoors, the health impacts, and mitigation strategies at different settings. We want to leverage the insights from the COVID-19 epidemic, engage with experts, and explore solutions to improve indoor environments, reduce health risk, and align air quality goals across sectors and regions. There are many growing evidence on the indoor air quality and health concerns over the decades. Studies from time activity budgets suggest that individuals are spending likely 80 to 90% of their time indoors. Therefore, given the large time spent indoors, the health impacts of indoor air quality has become significant concerns, particularly after the epidemic COVID-19. Well, the pandemic also improving the indoor air quality, highlighting the crucial impacts of indoor environments on human health and well-being. So efforts to reduce airborne transmissions of virus have not only helped manage the pandemic, but also improved overall indoor air quality, which has brought some insights of the indoor air quality management we can share from today's discussion. Well, indoor air quality challenges also vary greatly between low and middle income countries and high income countries. But they are also closely interconnected. In many places, household faces both challenges in household air pollution from using polluting fuels such as from the cooking, heating, and the lighting, alongside broader other indoor air pollutants. But also the issues caused by outdoor air pollution, infiltration, indoor human activities, and the building and construction materials also emit pollutants into the indoor environments. So these challenges often overlaps as economics grows. So today, we would like to have several speakers to discuss these challenging issues. We would like to gain a comprehensive understanding of the major air pollutants, their sources, including the emissions characteristics and exposure patterns in various global contexts. We want to recognize the major health impacts of indoor air pollutions. We want to discover the evidence-based mitigation strategies for the indoor air pollution reduction. We want to understand how indoor air quality issues intersect with other challenges of environmental health. The first session, we have two speakers. I will introduce them each one by one. The first speaker is Professor Jim Zhang, Junfeng Zhang, also in Chinese we call professor. He's a professor of global and environmental health at Duke University with over 350 peer-reviewed articles. His main research focused on the emission from solid fuels, uncovered novel health effects of air pollution in vulnerable populations, and he demonstrated the benefits of indoor air purification on health outcomes. So let's welcome Professor Zhang for his presentation on indoor air pollution exposure assessment.
Good afternoon, everybody. I appreciate this opportunity to I give a 10 minutes kind of an overview of what I think the most important points in indoor air pollution. We'll focus on solution. I guess what can we do? I hope that a few points can come through that way. All right, so I wanted to start with this slide to say that indoor air, outdoor air are connected. They're both are part of the atmosphere, and then, but also Dr. Huang mentioned that people spend most time indoors. So even for pollutants that generated outdoors, most of the exposure will occur indoors in the absence of indoor sources. So this is a typical example for places like Beijing. This is in 2013. You can see Beijing back to that time often, appear in news outlets, whatever, for a bad reason. We know that air quality is improving. This morning, there is a keynote presentation showing that improvement, but lots of other places are still going upward in terms of air quality, air pollution. This is a recent photo I took in Hanoi, Vietnam, that I personally can smell. I feel like I've swallowed air, in particular matter, other gases, because that tailpipes are very close to my breathing zone. So there's other places that outdoor air pollution is really very bad. We know that when that happens, the indoor levels of pollution will not be that different if the windows are open. For PM 2.5, about 70% of the levels outdoors, where NO2, inert gases. For ozone is the only one that is very reactive, so you have lower levels, but you still have some levels, or even actually higher levels when the windows are open. So what can we do? I think about 2013, when that photo was shown, I started to say, we know that air pollution is bad. We know that places in developing world, outdoor pollution was still at, very, up to 10 times higher than the WHO guideline or the national standards in different countries. So the policy, yes, will advocate control, bring down that, which we see in countries like China have done a great job in the last 10 years, bringing down air quality levels quickly. But that's 10 years, that's still a long time. For people who are suffering from asthma, you can't wait for 10 years, right? Especially for children with a growing body. So the indoor, that's the places we know, if we don't do anything, just stay indoors, 70% of outdoor levels, right? 80% of outdoor levels. So there's the engineering approach, there's purification through removing pollutants from indoor environment. For particular matter, the most effective way is HEPA filtration. We also have other technologies, but you got to be careful with the side effects. So I will focus on the HEPA filter. So I have done 4 studies since then, 3 in China, 1 in the United States. I have ongoing ones in US now. So and other people have published the papers as well in Taiwan, in Detroit, in Canada. So what we know now is intervention studies for a short duration. So, a few days to several weeks. I think up to a month in Taiwan. So children with asthma, this intervention is going to improve asthma symptoms, the respiratory outcomes, and in adults, either healthy ones, older people with cardiovascular or respiratory diseases certainly will improve their health outcomes by lowering blood pressure, improve vascular function, all that kind of things. So I would say that the evidence now on this short-term hypofiltration in the residences are pretty consistent. The thing is, what we don't know is can long-term use reduce actually disease incidence, right? Because short-term ones, you measure biomarkers, that kind of thing, but it actually will reduce the disease incidence or other clinical events. So that question still needs to be answered. And more importantly, what social behavior, all those things, is going to affect the effective use of the air purifier, those intervention. Like any technology-based interventions, if people don't actually use it or use it correctly, it's not going to cause much of the benefits. So we have one, I have two studies ongoing. I know Mary Rice is sitting here, she has one, maybe others have. Those are feasibility studies for long-term hypofiltration in improving cardiorespiratory health disease. In a few years, I hope we have data to report. So that's, given the places, and let's see, if in the developing world cities, outdoor air pollution is so bad, maybe there's indoor sources, you may be overwhelmed or overshadowed by outdoors. But we know that indoor itself has sources. Cooking solid fuel one, that's a big topic. I was asked not to talk about that because there will be separate sessions. But we know that there's lots of the other sources are there. And then, of course, in the modern buildings, we have those synthetic materials, lots of those chemicals over there. And then I will say, I get into this new line of research just started about ozone. I mentioned ozone levels lower compared to outdoors. That can be quite low, but why that low is ozone is so reactive, right? The NO2 is a gas. Why NO2 is 70–80% outdoor levels, ozone can go down to 20%. That's because ozone is very reactive. So they react with the surfaces. Indoor have lots of surfaces. The kitchen has lots of oily coatings. They love those chemicals. Ozone react with a double carbon bond. They react with a skin oil, also has those compounds. They react with the gas phase terpenes like a lemon, all those things give a good scent we're putting in. So that's why ozone is lower indoors. So that reaction now is a very well established literature. Maybe 500 papers in the last 15 years by the atmospheric indoor air chemistry community. Those are identified chemicals for that reaction. So we look individual compounds here, we know they cannot be good, right? Formaldehyde, the radicals, all that kind of things. So I was 2 years ago, when I was on sabbatical, I spent time with the people who are doing this indoor ozone chemistry. I try to say, they identify those chemicals, what is health effects, right? So I look into the data I collecting for some other purposes. In those studies, I collect outdoor ozone, indoor ozone measurements, healthy biomarkers. So use the ozone loss as a simple proxy for that reaction products, because so many hundreds or thousands of chemicals, it's hard to measure each one. But it's just to say the loss of ozone from outside into the indoors is proportional to that product formation. So use that, look into the panel, use a panel study, look into biomarkers, a relationship with the ozone and with the ozone loss. You can see actually after you adjust the ozone loss has more associated with more biomarkers of cardiovascular and respiratory biomarkers than ozone itself. That was in the children with asthma, 43 children with asthma, each person measured 6 times. You do that, changes over time on the ozone loss or ozone with the changes of the biomolecular levels. So this was done in 89 healthy office workers. Same thing. In this panel, we have a cardiovascular measurements, mostly arterial stiffness biomarkers, in addition to respiratory. We're showing the same thing. So this was published in the American Journal of Respiratory Critical Medicine. We say our findings challenge the conventional wisdom that indoor ozone concentration are too low to be a concern. As people may be affected by both the residual ozone, we do see that low-level ozone is still associated with adverse changes in those biomarkers, but ozone loss itself, that's the part you thought, ozone is low, it's lost, that's a good thing, but actually it's not. So how do we do about this? So I talked to the engineering people, Bill Nazaroff, Charlie Westler, and a few other people. It's easier than removing PM 2.5 because HEPA is more expensive, but activated carbon filters can be very effective in removing ozone. So the technology this can be done, but I think our knowledge is not there, have not recognized the importance of control ozone indoors because we feel ozone is an outdoor pollutants. So anyway, in summary, outdoor sources control policy in polluted cities is the key to improving indoor air quality. Indoor source controls, in addition to that, for short term, we need to find technologies to improve indoor air quality because that's more durable than doing the whole big atmosphere if we focus on just schools or classrooms or home. Indoor concentration reduction using air purification.
Thank Jim. Our next speaker for the first half session will be Professor Lidia Morowaska. She is a distinguished professor and Australian Lecturer Fellow at Queen's University of Technology, Director of International Lab for Air Quality and Health at WHO Center. Okay, welcome.
Where is the... Well, good afternoon, everyone. The key, that's not the first slide of my presentation. No, it just looks differently. Yeah, it looks slightly differently, but that's all right. The two keywords, so thank you very much for having me here. I'm really, really happy with this. And the two keywords in my presentation is exposure and health effects. So if we start with exposure, the exposure in different environments is very, very different. Jim already talked about this a little bit. And the point is that every environment is different type of environments, different activities, different physical dynamics, strongly depends on everything, what happens there. So this is the starting point, these big differences. Despite the differences, we have a general understanding, or we can classify what are the main kind of contributions from its sources. Sources we operate, introduce, conditions we create for biological agents, like for example, mold and dampness. We as a source, pollution that comes from outside, and all the factors, meteorological and so on. We won't talk about all of this. I just wanted to mention two of this. Pollution that comes from outside, and again, Jim already talked about this. I illustrate this with one graph showing how different these impacts are. And this is an analysis which we did with studies published at that time about contribution of to PM 2.5 and PM10 and particle number concentration, ultrafine particles in homes, schools, and offices. And then you can see that the situation is very different. In homes, particle number concentration, smallest particles originate from inside, larger particles come from outside. In the schools, the situation is the other way around. In the offices, modern offices, everything comes from outside. So you just see how different exposures are. And of course, this is the issue of S as a source, not just as a source of the particles, because the particles are not such an issue. The issue is if in these particles are pathogens, bacteria or viruses, this is then an issue. So, and we know that this results in health impacts. Now, summarizing the health impacts of indoor air pollution, in a way, we could do it with one slide showing this WHO air quality guidelines. 2021, the current values. Now, in what way we could do it? This saying that these guidelines apply both to indoor and outdoor air. Many people using the guidelines don't realize, and it is stated very clearly, that the guidelines are for both indoor and outdoor air and based on the data which apply to both. But we'll go one step further. Burden of disease. I will talk about this in a moment a bit more, but what I want to show is what health effects we experience indoors. So this slide shows contribution of indoor and outdoor, but if you look at the left-hand side, at the type of health effects. So basically, this is a long list of health effects due to air pollution inside. Now, the novelty of this work was not identify these health effects, but quantify indoor and outdoor. The health effects from air pollution, is this a novel thing? These are discoveries? Well, this is a picture from a diagram from one of our textbooks. This is the fact that we experience these health effects is a textbook's information, knowledge. So the knowledge is there. If anything, it's quantification of this. Airborne infection transmission, which COVID brought allowed us to focus so much, airborne transmission occurs through transmission, long distance, short distance, anything which we inhale. This is the most important aspect of infection transmission, and pathogens are part of air pollutants, which is not always seen this way. And we know how to reduce this. Ventilation. Of course, there are other means of doing this, but ventilation is the first what we need to talk about this. I'm not going to talk about the details of this work conducted in the Marseille region of Italy, but basically what the work showed that introducing mechanical ventilation in 300 schools out of over 10,000 schools show the significant impact. That's the last box on the right, and the scale is logarithmic, so we'll see how big the impact is. So these are the health impacts of air pollution. Now, what about burden of disease from indoor air exposures? So this is expressed in DALI, one of the, maybe not first studies, but one of the first systematic studies showing the impact in DALI in 26 European countries. So we can see all these countries, and here in blue and red we see contribution from outdoor sources to indoor exposures and what was generated indoors. As we can see, every country is impacted. Now, this slide from the same study shows something a bit different, which is exposure sources. This is, in a way, source apportionment. So the top diagram shows the total, the overall for Europe. The lower one shows for just for Finland. Now, the point is that if you look at this pie diagram, you can see that big part of this pie is red, and that red is PM2.5, and the redder red is PM2.5 from outside, less red is from inside. So you can see predominant impact on, in terms of burden of disease, of PM2.5. Of course, there are other pollutants as well. Similar conclusions were reached in other countries. This is a study conducted in the US. It shows on the vertical, horizontal scales, it shows all the different pollutants. The first one, very first one, if you can see this, and the highest is PM 2.5. So the same conclusion was drawn in China, in the US as well. Now in China, a very recent study as of 2 years ago published in the impact in residential houses. And on the left-hand side, these are the pollutants. And on the right-hand side are health outcomes. Now, it's a bit difficult to read this diagram because you see this sort of, the whole diagram is that one band because it is the impact of PM 2.5. So that one band of PM 2.5 impact on all the health effects. So there are impacts from other pollutants, but the impact of PM 2.5 is the highest. Interestingly enough, that study also calculated the economic impact of this. So in different currency presented here, but importantly, it accounted, according to the study, to 3.45% of China's GDP, over 3% of GDP of the country. And this is only residential houses. This is really huge. This is the same information, but compiled together for different countries. So the China, US, Germany, France, for whichever this kind of data were available. In each country, you can see that PM 2.5 is by far the most significant pollutant, and the order of other pollutants slightly differs. So, infection transmission, we cannot present it just the same way because this data is not collected in the same day, but we have statistics about the scale of infections, respiratory infections, colds, influenza, and so on. But at one stage, that was at the beginning of the pandemic, I found something about economic impacts of this. So the cost of COVID at that stage was $1 trillion, that's US dollars, monthly. Cost of other transmission in the US, and this was before the pandemic, was $50 billion annually. In Australia, smaller annually, but of course Australia is smaller. Interestingly, with this cost, calculations was, we always ask about it costs. We'll put sensors here, it will cost. Now, the cost of putting the sensors here is much smaller than costs which we are paying for indoor air pollution or infection transmission. To start doing something about this, with colleagues, we published this paper on healthy indoor air is a fundamental right. It may sound like, well, to call for action, but basically it was the blueprint for indoor air regulatory framework. At that stage was focused on infection transmission. I won't show the details of this. The point, however, is that we cannot, if we are trying to fix indoor air quality, we cannot just look at one aspect. We have to look at all the risks, otherwise we can improve one situation in one respect, but worsen in other respects. So we need to look about what's generated here, what comes from outside, infection transmission, thermal comfort, energy, all this has to be taken into account. And to address this point with a large group of colleagues from around the world, at least one person is here, Giorgio. I don't know whether anybody else is here, over 40 scientists. We've reached this scientific consensus on mandating indoor air quality standards for public buildings. Which pollutants, based on what, which levels. And governments around the world are looking at this now. I'm pleased to show this photo with this gentleman in the middle, next to me in red, I always have something red, is the Australian Prime Minister. So hopefully step by step.
We have, thank you for the two speakers, the wonderful sharing of the insights of the questions. We have several minutes for questions. And if you would like to have a 1 to 2 to each of our speakers, we have the.
Fanny Castillo del Ministerio de Salud de Panamá.
Fanny Castillo from the Ministry of Health in Panama. I work at the Directorate of Environmental Health. Concerning the schools, was very interested to see that you have conducted studies at schools. I mean, they have air conditioning and all these systems because they're in Europe. Not necessarily, okay. In Panama and in our schools, many of them don't have air conditioning system, and it is as hot as it is here. So depending on where you are located, there is a lot of dust, and that their equipment that detects high levels of PM 2.5. Is there any sort of a study concerning the content of dust in the air? Because in Panama we have two shifts, one in the morning that is from 7 to 12, and another one that goes from 1 p.m. to 5 p.m. And of course the ones in the afternoon, their performance is a little bit lower, poorer. And I have detected that, but I don't have studies because it could be due to the heat and also the content of dust, because many they're close to rural schools, close to the streets, and dust comes through the windows. So is there any reference about that situation?
Going to. Now, that was that slide in which I showed concentrations between PM 2.5, PM 10, and particle number concentration in schools, offices, and homes. This was based on studies published in different countries on concentrations of these pollutants in these countries. So what the reason why the main contribution from PM 2.5 and in particular PM 10 at schools it's coming from indoors is because of this being an indoor pollutant, particularly brought by shoes by kids playing from outside and resuspension of the dust. So there was quite a lot of studies. That paper was published quite a few years ago. I can send you the reference of this, but it's based on papers published, and so there have been appeals in. But as I said, this is quite distinctively because it's resuspension of dust at schools, which is not the case at home. At home, the anything of that size comes from outside.
Thank you, Isabella Nisi Maisano. For Lydia, I know that you work on ultrafine particles. Can you say something about having some indication standards for indoor air and outdoors too? Thank you.
Well, I will have a presentation about this tomorrow about ultrafine particles, but I'm extremely happy and extremely proud that in the last edition of the update of the WHO guidelines, we have a good practice chapter on ultrafine particles. So in there are quite a number of aspects. So in particular, we defined typical values. We cannot give recommendations like WHO guidelines because there's no exposure, not enough exposure response studies. So that's the problem. However, there have been enough studies to come up with typical values. So based on this, typical values can be used as a kind of benchmark for countries. But also we defined quasi-ultrafine particles, because the problem with the definition of ultrafine particles is that particles smaller than 100 nanometers. But the point is that unless you have an instrument like scanning morbidity particle sizer, which measures the size distribution from which you extract particles smaller than 100, you cannot get it. But quasi-ultrafine particles include also larger particles, because concentration of them is relatively small, but this way you can use, for example, CPCs for this. But I'll have a few more words about this tomorrow. Invitation for everybody to the session tomorrow.
If I may, I would like to have a question to our first speaker. I'm Giovanni Viegi from Italy. I would like to know if there are recommendations on when is to be used the air purifier. I think probably when the level of outdoor pollution is higher, or also it's something that, for instance, where gas cooking is used, should be recommended. And in your experience, how much is the adherence of people? So they buy it, but they use.
Yeah, that's a great set of questions. Three questions. The first one is when the air purifier should be used. I think that really depends on people, the individual susceptibility to air pollution. I would say also depends on where you live, right? So I think probably a good sort of rough guideline is looking to the health-based recommendations from WHO, from EPA for the outdoor standard. If the level is above that indoors, I would say definitely use air purifier, right? But even below that, we do know that large epidemiological studies show that PM levels below the current EPA standards or whatever levels still showing adverse health effects. So if individuals who are very susceptible to pollution, I would recommend to use them whenever they can. I would use, I use it when I have in the kitchen, cooking. I know that the products are generated, and I use it also in allergen seasons because of the pollens they remove. But that's not the regular PM2.5 we're talking about. The second question is the adherence of using this. So we have this. I mentioned about this long term, which means close to a year intervention. We already saw that it really depends on individuals. Some households, after a week or two, you will see they're not using because we have a monitors of indoor PM2.5, outdoor. We see that indoor-outdoor level pattern changes indicating that they are not using it. We sometimes remind them, but because it's a natural trial, we cannot really force them to change it. So that's why I feel this implementation science, which including social behavior component, will work for if we really want to have a sustained benefits of this technology.
Thanks, Jim. Thank our speakers. I'm sure there will be many interesting questions to be communicated after. We still have time after work, after the session. Now we need to move on to AJ.
Hi there, Jay Pillar-City from UC Berkeley. I'm going to be moderating the discussion today. So I think we'll go ahead and have the panelists come on up. Professor Zhang, Professor Roska, Professor Rice, Professor Buonanno, and Professor Xiaoming. And we'll go ahead and get started in the interest of time. And so Professor Zhang is going to first tell us a little bit about exposure.
I think I was asked to give a few slides, sort of let's see, to talk about what to measure. I think that was I was assigned to do for this discussion. So we know numerous chemicals, numerous, including emerging ones. What to measure, how to measure, relevance to human health. There's always this question about to measure a single compound or measure mixture, right? So that's outdoor pollutants going into the same kind of challenges. The indoor is extremely, I think, important because there's just so many compounds that are present, those mixtures, including if you count on biological agents, that would be even more complex. So, but single compound, we now have a guidelines, whatever, right? We know that some countries actually have indoor air quality standards, like China. They have a formaldehyde, benzoyl a pyrene, have those things, benzene. But we know that if we do the indoor concentration, measure them as formaldehyde concentration is this, and then the standard is what? That's simple, right? So, but the reality is that that's not what people are exposed to. In the real world, we're not just exposed to formaldehyde come out from some emissions from synthetic materials. That comes with the other volatile organic compounds, right? So the thing is, what is really, you know, the people experience, the effects is really the mixture. So then this National Academy's report came out, says, well, there are two ways to measure this. One is so-called top-down, which means you measure everything you can with the very good mass spectrometer. Then you add, you know, there's hundreds of chemicals you measured. The bottom up is that say, well, let's go with the sources. You know, you have those cooking emissions. You know what are coming from that. You have a particle board. You know which chemicals come from that. Some, you know, shampoos have something. And then you through the source emission factor, you back calculate what is in the air, right? So those are the two approaches you can do. But that really doesn't answer. You know, we can measure everything, but really, do we need to measure everything, right? So this is really relevant to the health. So then this targeted chemical analysis is based on if we know a bioactive equivalent kind of quantity, so sort of like a toxicity measure, and then you can integrate them. You know the concentration, know the toxic potence, toxic coefficient or something, that you can add them together. So that's probably one approach seems to be sensible to do if we want to really know the cumulative risk from everything that's present in the indoor environment. So the ones that doesn't have a toxicity, that slope factor will be 0, that you don't count it. And ones really have a higher toxicity, you have those, you know, 1, than the ones that less tox, 0.1, 0.2, then you add them together, you have got a single measure. So the thing is that how do you determine that toxicity? Based on mortality or based on, you know, carcinogenicity, neurotoxicity? I think based on mortality, it's very not realistic because, you know, it's not going to have that much data to relate a single chemical indoors with the death kind of, you know, dose response relationship. So it has to do those things. So the toxicologist, you can use those different assays to determine that relative toxicity. You can do that. But this paper demonstrated that the other way you do is you don't do individual one, measure that integrate them together. You just say whatever is there, the whole mixture, like what I showed you in my study, ozone loss, instead of measure every formaldehyde, organic oxides, that kind of thing, and then weighted by the relative toxicity, but measure just the whole thing. What's that whole thing? Well, I use the ozone loss, right? So how maybe you can just grab that indoor air, putting in a toxicity kind of testing system, right? That could be in vitro, in vivo, use the animals, use the human chamber studies, that sort of thing. So you could do that, and then compare with the individual compound-based, which is also directly related to the guidelines or policy or that sort of thing. So this paper shows if you do that, the total is that ice, that whole ice cube there, or ice, whatever that thing. But you can identify it through that individual ones, it's just the tip of iceberg. So there is lots of challenges. I don't think I have an answer here, but I just wanted for us to think about. We know that there will be lots of things in the indoor air, but how we're going to really measure and what would be the most, meaningful thing in terms of to predict the risk. Because because that's the ultimate goal, right? How to get the risk estimated, how to control. Thank you.
Thank you. Professor Marwaska, we had a couple of questions for you that dovetail nicely with what Jim just mentioned. The first one is, what are the most pressing health impacts of indoor air pollution that policymakers should address immediately? And relatedly, the second question, what are the major gaps in our understanding of the health impacts of poor indoor air quality?
Well, I will probably turn those questions around. We understand what the health effects are. We don't necessarily understand what the health effects are in this room or in another room, but in general, we have a very good understanding what the health effects are. So that was a slide I showed that this is a textbook information what type of health effects are. Now, in terms of the knowledge gaps, now, if we were to use what Jim suggested, of course, we can bring mass spectrometers here and we can measure absolutely everything, establish everything. We can maybe do this in the whole center, but that's it. We cannot do this across the whole city. So, but this is not really a knowledge gap as such, because there's no way we will ever have this information and this one. The point what the policymakers should and could do is to mandate indoor air quality standards. Jim mentioned that countries like China have indoor air quality standards. That's very true, but these standards are not mandated. A few years ago, together with Wei Huang, we did a review of the status of indoor air quality standards around the world. We found that out of the 100 countries which we reviewed, 140 countries, 20 of them had something mentioned about indoor air quality standards, but none had mandated indoor air quality standards. Since then, the situation slightly improved, that some countries have, but they don't require real-time monitoring, but periodic monitoring, which doesn't still give you information. So the reality is that we must have indoor air quality standards. But having indoor air quality standards means continuous real-time measurements. And certainly, we won't measure all of these pollutants, which Jim listed, because there's no way in the world of doing this. So that paper which I've mentioned, sorry, I didn't realize that I could have slides for this, but we came after long discussions of what can realistically be measured in every space, and that's what we are talking about, every space and every public space, because we cannot mandate indoor air quality standards in public homes. We cannot ban smoking, for example, in public homes. So we are talking about public spaces. We can monitor PM2.5 sensors. Low-cost PM2.5 sensors are really up to the standards now. We can monitor CO concentrations. We can monitor CO2, I'm looking at this, and CO. CO low-cost monitors are also very reliable. And now, there's a whole list of other low-cost sensors which can be used and being used for research purposes, but interpretation of data, like, for example, from ozone low-cost monitors or from NOx, requires interpretation, and this would not make them suitable for this purpose. But with these three pollutants, we can do it, and the third parameter which recommended for mechanically ventilated houses is ventilation rate as such. Now, of course, it doesn't address all the pollutants, all the chemicals, but if one big aspect of this is improving ventilation, which is removal of pollutants, which if we remove stuff which was generated here, we also, well, like by people, we also remove VOCs which are generated here. So it's not a full, complete solution, but we don't measure in real time VOCs in outdoor air either. So we have to be pragmatic. So these three pollutants, and the rationale for this is based on the WHO guidelines for PM2.5 and CO. And for CO2 is based on a scenario of a classroom of 25 people, students, one infected, spending 1 hour, and then keeping the ventilation such that R0 is below 1. So that's the idea. And by the way, what do you think about the ventilation in this room here? Now, in our, what we propose in our blueprint is 800, below 800 ppm of CO2. Unless it's recirculated, then the difference between what comes in and out 350. I don't think it's recirculated. So do you think ventilation here is good or not? Who thinks is good? Who thinks it's bad? I think everybody is very they cannot, that's right, yeah, but that's why everybody is very cautious, because it's now 941 and increasing. Ventilation in this room is worse and in the big so as I said, little think and tell us. Now, with this information, we could do something immediately, and there were many situations where I immediately demanded action. Like that action could be, if there is mechanical ventilation, it can be stepped up, something can be opened. There were many situations when I induced action, immediate, based on what I can see here. I can talk about this for another hour, but I think I'll stop.
Thanks. That would probably benefit us all if we could hear another hour. Unfortunately, we have to move on. And that was a great segue into Professor Rice's discussion around the real-world effectiveness of filtration and ventilation and when and where it should be used. And just as a brief introduction, Professor Rice is the Mark and Catherine Winkler Associate Professor of Environmental and Respiratory Health and Director of the Center for Climate Health and the Global Environment at the Harvard T.H. Chan School of Public Health. Over to you.
Thank you for that introduction. So I was asked to talk about practical matters, and the reason I was asked to talk about this, I believe, is because I am doing a very labor-intensive, 1-year-long randomized controlled trial of HEPA filter use for patients with lung disease. So some of what I'm going to say is lessons learned along the way of doing this research. But I'm going to start first by talking about ventilation. So indoor air pollutants include everything from combustion-related pollutants that come from the outdoor air, as Jim discussed, from our furnishings that emit VOCs, from the ground and the water, which are a source of radon, which is a major cause of lung cancer, also an indoor air pollutant, and also our cooking, which is a source of gases, including nitrogen dioxide. And all of those build up in the indoor environment if we don't have adequate ventilation. So it's so important. But at the same time, as we are striving to improve energy efficiency, especially in cool environments, there's a risk that indoor air quality is overlooked as a priority as we make our buildings tighter and more insulated. And in fact, that's been shown in real world settings, that buildings that have been retrofitted to be more energy efficient, if you're still using natural ventilation, indoor air quality gets worse and can then become worse than the outdoor air quality. So another practical consideration is that some of the technology can be very misleading. So kitchen hoods, for example, some of them just filter the air and recirculate the gases in the indoor environment and don't ventilate to the outside. So that's important to keep in mind, that we're really talking about ventilation when you're considering what technology to install. But is it effective? Yes. So when kitchen ventilation systems that ventilate to the outdoor environment are actually used, they're very effective at reducing particles and gases and VOCs. And there are health studies. There's one that was study in particular I'd like to highlight that was done in China. The first author is Zhao and Plasmed, 2014. 9 years of follow-up looking at just ventilation alone, and there was improved health outcomes, better lung function, reduced incidence of COPD. So just the ventilation piece is really important. And for radon, I would add that beyond addressing the construction materials, ventilation is really the intervention that you need to look at. Some of the challenges, I talked about misleading technology. People may not use their ventilation hoods in their kitchens because it costs electricity and it makes a noise. And it's even been shown that people tend to over-report how much they use them. And very importantly, has been mentioned a few times now, when we bring the outdoor air inside, we bring in the outdoor pollutants. And so that's why filtration is so important. So a few comments about air filtration. So as Jim mentioned, really two major systems, HVAC systems and plug-in HEPA filters are the two I want to talk about. And typical building HVAC systems have a MERV, mechanical efficiency reporting value of 8. That reduces particle levels by about 20%. If you upgrade to MERV 13, you bump that efficiency down up to 80%, 80% particle removal, really big difference. And HEPA filters, when they're appropriately sized for the room, as Lydia was discussing, with an appropriate clean air delivery rate for the size of the space, reduces levels of particles very well. So in our experience in Boston, 50% reduction in concentrations of fine particulate matter. Charcoal filters can help lower gases and VOCs, which are also gases. Although I can't yet look at all of the data from my trial, I'd like to point to Nadia Hensel's trial, which is one of the few long-term HEPA filter trials that I know of. So they put portable HEPA filters in the homes of people with COPD in Baltimore for 6 months, lowered PM levels by 50%, and lowered NO2 levels by 28% with a charcoal filter. So not bad. And the sort of practical considerations that I would highlight, in addition to making sure you got the right size, again, it's compliance, because these machines make noise. Some consider it to be white noise, but in my own trial, I really have challenges, and I hear a lot from the study participants about using those in their bedrooms. And if I were to pick one room that would be the most important, I would actually say it's the bedroom, because you know the person, your patient, the person you're in front of you spends hopefully at least 8 hours a day there. So that's an ideal site to use them, but noise and electricity costs, and there's a real equity issue there as well, right? I hear a lot about the cost of the electricity bills in using 2 HEPA filters. So I'll stop there and look forward to the discussion. Thank you.
Awesome, thank you. Professor Buonanno is going to tell us about indoor air quality and viral transmission, and he is professor in the Department of Civil and Mechanical Engineering at the University of Cassino and Southern Lazio.
Okay, first of all, good afternoon to everybody. When I prepared this presentation, my intention was to give an example, a case study for the discussion. But I was not thinking that one of the speakers was Lydia. I have a very strong collaboration with Lydia, so some of the slides are reported here, but my comments will be different in some way. Anyway, the problem of indoor is that each environment has an own dynamic. And in particular, this is one of the slides. If you consider as an example schools, you can see that the large particles, PM10 and PM2.5, are generated from indoor, and ultrafine particles comes from outdoor. This is the typical dynamics. Of course, you can have also in some cases the generation of ultrafine particles from indoor, also when you don't have combustion sources. So you can see here what is the typical management that we have in classroom. We try to manage indoor air quality, for example, by opening the windows. And is there a laser here? No, okay. You can see the blue bar, the bottom on the figure, represent the time where the windows are closed. And you can see the trend of ultrafine particles, black line, outdoor and indoor, that is the red line. And the green line is the CO2, are the CO2 values. So each time that we open the windows, we observe a decrease of CO2, and this is good, but an increase of ultrafine particles because there is the penetration of these particles from outdoor. And you can see that if we increase on the right side the time for each hour that we open the window, the concentration of ultrafine particles in indoor will be quite similar to the outdoor. So in terms of ultrafine particles, this is not the best way to act. If we consider now PM10, the situation is different because we have some events in indoor of generation due in particular to the movement of the students, so resuspension. So we have a generation in the classroom and the ventilation cannot reduce this PM10, but there is not a very strong correlation. What we did is to install a mechanical ventilation system in these classrooms. And you can see that when we have a constant value of CO2 because of this mechanical ventilation system, we have also a difference between outdoor and indoor ultrafine concentration, particle concentration, and similar values of PM10. So it means that if we have a mechanical ventilation system, we can reduce, we can improve the air quality in this classroom. Now, what about respiratory particles? Because air quality means for particles not only environmental particles but also respiratory particles. And we did, together with Lydia, a study in the Marche region. In the Marche region, the government of Marche region funded the installation of more than 300 mechanical ventilation systems in the classroom during the pandemic. This is very important. And going directly to the results, you can see that if we increase the ventilation, of course, we can observe a reduction of the number of cases that is a function of the level of the ventilation. And another important result, if you can see the red line represents the value estimated by a tool on the basis of the scenario condition. So we can in some way assess the risk. Why this study is very important? This is a very simple study, but it represents, in my opinion, a kind of Halley comet, because we had at the same time different waves of infections, different level of ventilation, and the monitoring of infection day by day, because it was done during the pandemic. And this was the reason why this is the only paper that was cited by the NIOSH for the recommendation of 5 air exchange rate in indoor environment. So in conclusion, we can manage exposure to environmental particles through ventilation, of course, air distribution or filtration, of course, and we can assess short and long-range airborne transmission of respiratory pathogens. In my opinion, it's time now to put together the engineering area and the medical area. And this is what we are doing. I invite all of you to participate to this conference that is co-organized by the WHO, the CERN, and my university, that will be in Italy in less than 2 months. So thank you.
Thank you very much. I'd now like to invite the Deputy Director General of China CDC, Xi Xiaoming, to tell us about China's experience with their indoor air quality standard.
Thank you. This morning, Professor Xin introduces the clean air actions and health benefits in China. And this, I will introduce the China's experience in indoor air quality standard, which is issued in 2022. I was responsible for the revising with our team. So I will very quick and introduce three parts. First, as we all know, people stay for more than 80% time indoors. Indoor air pollution poses critical challenges to global public health and contributes to great disease burden, which was estimated to be approximately 3.2 million deaths in 2020. And this is the national strategies on the indoor air quality. China attaches great importance to the indoor air quality and releases a series of plans and initiatives strengthening indoor air hygiene management, achieving carpet smoking ban in indoor public spaces, because the smoking is a very serious problems in China, and also preventing indoor air pollution. And from 1996, China has issued many indoor air-related construction and decoration-related quality standards, such as the hygienic standard of hotel, labeled with GB. GB means National Compulsory Standards, serving as important guarantee for people's health. These standards provide important knowledge basis for the development of indoor air quality standards. China is one of the earliest in developing countries to issue this standard. The first edition was issued as early as 2002, paving a way for the improvement of indoor air quality. Why did China issue the standard 20 years ago? The most important reason is the popularity of indoor decoration in urban areas, which increased exposure to indoor air pollutants, such as formaldehyde and benzene. In addition, existing standards at that time were only limited to a single size without residential or office spaces, or limited to a single air pollutant. Then the aAQ standards were issued, containing 19 indicators with corresponding monitoring and testing methods. Why did China revise the aAQ standards and release in 2022? Over the past 20 years, rapid urbanization has changed the pattern of indoor pollution, especially PM 2.5 and PM 10, attracting widespread attention. In addition, China issued Healthy China 2013 blueprint, emphasizing to integrate health into all policies. This morning, Professor told us many measures to control air pollution and also the energy transition, and generated new localized health evidence and good practice. The newly revised standards for IAQ emphasized on the health leadership, containing 22 indicators, including 3 new indicators such as PM 2.5, TCE, and PCE, and also include the monitoring and testing methods. Then I share some experiences in this standard setting. Firstly, we adhere to principles addressing health priority and evidence-based data. For example, we prioritized health risk assessment approach to develop indicator limits. Secondly, we tightened the limits of 7 indoor air pollutants and added 3 new indicators. For example, the limit of benzene was tightened from 0.11 to 0.3. And we added the limit of PM 2.5, which is lower compared with the ambient PM 2.5. Moreover, the revised standards are more likely to be implemented. We adopted short-term indicators and set the detection time at our level. All indicators are equipped with test methods considering their accuracy, no noise, and portability. Finally, the implementation of standards for IAQ in China has brought substantial benefits. From 2000 to 2017, the exposure levels of most indoor air pollutants decreased significantly, such as PM 2.5, nitrogen dioxide, and sulfur dioxide. The implementation leads a 20% decrease in daily related to the indoor air pollutants. Especially in rural areas in Beijing, the implementation of coal ban and clean heating program cut down about 90% indoor source PM 2.5 concentration compared with the coal-based home heating. And this is all of my presentation. Thanks again for the organization of WHO and Colombia government. And this also is advertised. The 5th China Conference on Environmental Health will be held in Hangzhou, China in August 2025. We are delighted to invite you to attend if you are interested in the air pollution, also climate change and health. Thank you.
Thank you all. That leads pretty nicely into the first question we have here, and that is, what are some of the successful examples of policies, regulations, or initiatives that have improved indoor air quality and protected health? And do any of those have lessons that could be applied globally? And perhaps, Lydia, we could start with you and your discussions with the Australian government about indoor air quality standards.
Well, we started those discussions kind of in a serious way last year. The biggest question was to which government department this would belong. Because when we are talking about outdoor air quality, it's very clear that there's one government called EPA, or however it's called in different countries, no discussion. But buildings belong to different departments. So hospitals and so on, Department of Health, schools, Department of Education, and so on. So who should take care of this? The starting point of the discussion was the Department of Health, but of course that's not their responsibility. They cannot be. So the government, so the Department of Health, and I'm talking about Federal Department of Health, is now doing a lot in terms of guiding this. But clearly, they are not going to mandate this. So then we all looked at the Department of Environment, and there's some rationale in this because, after all, they do monitoring, and the outdoor air has such an impact. There was some level of interest in this, but not at the top, and it was very clear that that wasn't going to go this way. But since we are talking about public buildings, not residential buildings, because we cannot mandate air quality, we are talking about public buildings. Every public building is workplace. And therefore, this is now pointing very strongly to the workplace. In Australia, the name for this is Safe Work Australia, as the most relevant body to mandate standards like this. And there's already a framework for this. For example, in Australia, CO2 concentration, according to Safe Work Australia, is 5,000, but that 5,000 is in relation to procedures. But now it is only lower the value, but it doesn't require bringing something new. So now we are working closely with this area of the government, and I'm hopeful that this will bring us somewhere. But this was really the key point to where is the home for this standard.
Yeah, thanks. It's really helpful. Others? Yeah.
I have another, perhaps less well-known example. It's a rural example in Libby, Montana. There was a collaboration between the University of Montana, where some modeling showed that one of the reasons the area was not meeting air quality standards was actually wood burning in people's homes. And so they offered an exchange program. At least 1,000 wood stoves were exchanged, and it improved air quality for the region. So PM levels went down by 20% due to the program alone, it's been estimated. And also, when the homes that exchanged the wood stoves were monitored, there was a 70% reduction in indoor particulate matter. So I think it's a nice example of academic government partnership and incentivizing change. And I really think there's an opportunity there for different sectors to think about combustion-free buildings as a goal. Yeah.
Anyone else on the panel?
I would like to repeat some consideration of Lydia, because in my opinion, we have to shift from voluntary guidelines to mandatory indoor air quality standards. This is something that is reported in the science paper. In the science paper, we propose PM 2.5 because it's the most important pollutant. CO as a marker of combustion sources, and CO2 because in some cases it could be a pollutant. For example, in bedrooms, high concentration of CO2 decrease the sleeping quality. This could be a problem. But in particular, because CO2 is a marker of not ventilation, but rebreathed air in some cases of ventilation. But this is only the first step. The second step in this paper is the implementation of a real monitoring system. Because Lydia, and this is also I use also this kind of sensors. We can monitor on a personal base, for example, CO2, but this is something that could be monitored in this room directly. And in Belgium, it was approved a law, mandatory law, that starting from 2026, in each public space, the CO2 will be monitored. And so each people could will see the real value, and they propose a universal value of 900 ppm. This is not the optimum because the optimum value depends on the scenario. But this is a very important starting point in order for the people to understand the problem. Because in my opinion, the challenge is not a technical challenge or a scientific challenge. Now it's a political challenge. And this is very important in my opinion.
I can add very quickly to this that real-time monitoring. It's not an announcement like this yet, but hopefully announcement soon. The building, the university building in which we are, which we monitored and fought with the university to improve ventilation here and there, will become the first building in the world to comply with the proposed indoor air quality standards. So we are in the process of placing sensors that, according to the science paper, everywhere. The university agreed to, and this will be on all the open platforms so that everybody can see this. And we will demonstrate what had to be done and what was the cost of this to bring improved ventilation. In some places will be ventilation. But ultimate goal is this, that within 3 years, this building will be completely compliant with the proposed indoor air quality standard.
I agree completely on what you said about the workplace being an opportunity and a good place to start. And thinking about success stories, we've talked about tobacco a lot, and that success story really began in the workplace. It was about protecting workers from secondhand tobacco exposure. And in the United States, the majority of states, at least 28, have a ban on smoking in public places. Schools would be another one, right? And when I was talking about different challenges of maintaining air filters, for HEPA filters, there's also the replacement of the filters and the vacuuming of the pre-filters. That's very hard for people to maintain, but in settings like the workplace and schools, where people spend so much of their time, that can be done.
Yes, I have 3 points. One is for the clean energy policy. It is very important and for the clean clean air. Second is the same is that the smoking tobacco control, especially in the indoor area, especially in the office, at home, and etc. And also, I think the clinical doctors is very important to tell the citizens about the information of the standards and also the air pollution information, and including the indoor air pollution and outdoor air pollution. So this is the idea.
Okay, I think we're just about out of time, so let's give a big round of applause. Okay, yeah. And so just some key messages and thinking of some next steps, and I welcome any reflection from the panelists as well. One is that obviously indoor air quality is critical given the amount of time we spend indoors by the global population. Two, improving indoor air quality brings significant health benefits and contributes to broader air pollution reduction efforts. And three, lessons from COVID-19 provide valuable insights into practical interventions that can contain airborne transmission of viruses and reduce exposure to indoor air pollutants. And I had a few additional reflections. The first was just thinking a little bit about more refined indoor characterization with an emphasis on potential toxic potential, as Jim talked about, versus measuring what we know how to measure and can measure inexpensively and well. And I think there's a little bit of a tension there, but both probably have some merit moving forward. And so it's balancing some of that sophisticated measurement with practical and implementable measurement regimens. A second is translating what we're learning about the impact of filtration and ventilation in indoor environments to guidance both for individuals, policymakers, and regulators. And this gets to some also of what Jim mentioned around bringing implementation science into the fold to understand, if you're not using your mechanical ventilation over your cooking surface, why not? And what can we do to motivate that transition? And then broadly thinking about the costs and effectiveness of the filtration interventions and who they might be most appropriate for. To Professor, I'm so sorry about my pronunciation of the name here, Buonanno's points about consideration of trade-offs with simple ventilation interventions and what that might mean for exposure to other pollutants. And then finally to some of the points around regulation. So who regulates indoor spaces? And as we're thinking about adopting these guidelines, who should be targeted and should they become eventually mandatory guidelines? So just a few final reflections. Thanks again to everyone and to the panelists.